Right, so hello everyone, and thanks for the opportunity to talk to you about our pathways and some of the challenges that have already been alluded to, and you put in the slido about this particularly thorny issue in the paediatric emergency department. So my name is Matt Edwards. I am the clinical lead for the paediatric emergency department here at King's College London Hospital and Denmark Hill, and I've also got my one of our PEM trainees registrars, Trisha Gupta, with us, who's been working on a quality improvement project surrounding this particular problem. I've been working with our orthopedic surgeons over many years surrounding a few different parts of our paediatric orthopedic issues, and this one is a particularly thorny one, which hasn't gone away. It's not, we have to be cognizant of the challenges we have in our departments, whether that's a specific paediatric ED or not. And I think that the BOAST guidance, because I also sit on the best practice committee at the college, did come through with a degree of controversy in that I think it did feel like the orthopedic teams are saying, like, this is something that should be provided in the emergency department. And certainly in our department, there was definitely some controversy about manipulating these fractures where often there was the viewpoint or feeling within the department that this is something that is better dealt with under GA in with an image intensifier and all these kinds of things that would be able to do it. Now I actually sympathise with the BOAST guideline. I think it's true. I think that the minute being able to deal with a child's fracture and straightening out and it feels very much like bread and butter paediatric emergency department work. So with that in mind, I'll talk to you a little bit about our journey and where we're hoping to get to, and because we're certainly not perfect, and I'm sure none of us are. We came from the perspective that with limited capacity and experience for paediatric procedural sedation and the limited capacity, we needed to come up with a better solution. And we've already had the Nottingham sort of guideline alluded to, and hopefully I'll be able to explain to you what that is a little bit more. So make the distinguish that in the various different ways in which you can deal with this. So historically in RED, we essentially, for a forearm fracture, the options were these: conservative management, whether it be splint or just a cast or whatever, manipulation or if under GA, or the procedural sedation in the ED. And those are the three things that could be provided. The procedural sedation in the ED was, as I'll point out later, it was pretty much exclusively for patients who were limb threatening with like a pulse that wasn't there or neurological deficits, etc. But that was pretty much limited. So we pretty much were limited to conservative management or pretty much GA. And then obviously we had the BOAST guideline, which has been alluded to, but basically they're saying that all units managing child's forearm fractures should have the protocols to enable early definitive manipulation. And that's an interesting point in this, that this is, that we are looking for definitive manipulation. So we recognized that there was a subset of patients that we could start manipulating these patients as a definitive aspect of their care, get really good results, with less fasting time, less staff time, less risk, etc., and by adopting a slightly different strategy. And the Nottingham pathway said, I actually don't know who in Nottingham sort of had started all of this, but as I said, it's certainly one of our orthopedic surgeons came to us and said, look, this is what we were doing when I was working in Nottingham. Just have a look at it, see what you think. And we did. And it basically came down to play therapy stroke distraction techniques Maximal oral analgesia on arrival, and then the use of intranasal fentanyl just a bit before, and then utilising Entonox. I think soon we'll be looking at Penthrox as well. But essentially, it was taking the strategy from this to then offering this. So not procedural sedation, but procedural analgesia for specific fractures that would be able to be manipulated definitively with the gas and air and the strong opiate. These were the kinds of fractures that fit within those manipulation pathways. As we said before, the periosteum being intact, and so there needed to be these kinds of criteria for us to be able to do this. And really, this was kind of in discussion with this orthopedic senior at the time. So, like, is this going to be, as per the Bose guidelines, a definitive manipulation? So one of the issues is that any quality improvement project, we're looking at multiple stakeholders, and the biggest stakeholders actually in this whole thing actually are our nursing staff, because one of the other things you don't really need necessarily, unlike in a sedation, is a senior airway trained person to be able to deliver procedural analgesia in these types of cases. Sorry, I forgot to say that there's also a bit of an age cut-off, and they do have to be old enough, obviously, to be able to use the Entonox and be able to comply. But those tend to be the most active kids anyway, so we haven't had too much of a problem with the much smaller kids. But this was a survey that we did looking at for the perspective from our nursing staff surrounding our senior nursing staff surrounding this protocol, what we were suggesting. And as you can see, a large proportion, sort of 2/3 there, saying not a fan of manipulating fractures. I think they should be referred to the orthopedic team for manipulation under GA. So we had a bit of work to do there. So if you felt that wasn't the problem, like, what were your problems? So we looked at these and we said, right, this is what we're going to target to sort of work out if this is this a thing. So basically concerns that the intranasal opiates would not provide enough pain relief, that the fractures were not being manipulated by people who would give them the definitive manipulation, and that essentially we didn't really have any internal guidance suggesting that this was safe or whatever. And I think there was also a historic concern surrounding the kind of situations whereby there would be, in the middle of the night, there'd be an orthopedic SHO saying, like, we don't need to admit this child, they just need to be sort of manipulated into a cast and they can go home. And then the pediatric emergency department going, no, well, we can't do that, so you're going to have to admit them. And then there being these situations where this manipulation would happen with suboptimal analgesia in some side room whilst the arm was going into a cast, and some anecdotal, quite sort of distressing scenes of quite significant pain from these children. So there was a lot of pushback from the nursing staff about whether this would be something that would be good. So part of that initially required, even though now it doesn't require a consultant to be there, as a consultant group, what we did was we were there for all of these. And so we started to see some really good success, and it became part of the sort of the proof is in the pudding, as it were. And so this is a great, nice example of a manipulation that was done using procedural analgesia, and the kind of time period that they had, and so discharged within 4 hours. So everyone's kind of happy. We did look at sort of the parent acceptability, and so we did have a contact of a lot of the parents, and sort of said about whether they felt the patients were particularly uncomfortable with it, and it seemed like this was pretty supported. And so that we had the things. What we did was the consultant sort of being there to start this whole process, and then essentially as a department it became a bit more of a cultural thing that we could do, but it really required getting that buy-in as we went. And then so you can see, so this is relatively old data now, it's 2 years old. You can see the sort of rate of us being able to perform manipulation in the ED started to gradually climb, and it's continued to do so. The rate of patients coming in and getting a GA Because the interesting thing is that if you speak to the vast majority of pediatric anaesthetists, and I've done a straw poll of 5 on my WhatsApp group very recently, and said, like, if a procedural sedation wasn't available in the emergency department and this kid was being admitted, well, would you just do procedural sedation like we would do in the emergency department, or would you do a GA? And they'd all do a GA. So this was actually saving generalized. Apologies about the siren. So you can see there, dropping that, and also, it became cultural throughout the senior on-call orthopedic team as well. The orthopedic registrars were like, yeah, this is brilliant. You get this done off the CPOD list. Perfect, great. There was a lot of controversy though, in our group, and basically the ED consultants sort of going like, well, I was always told a lot of these patients needed an image intensifier, and we're not providing that. So surely this is worse care. And like they're saying that they want to have a GA so that they've got significant relaxation of the muscles and stuff like that. So are we providing poorer care just so that a kid doesn't go onto the CPOD list? I think over time, again, proof is in the pudding, and we've got all these series of kids who have, really good outcomes, and that seems to be winning people over. But it said I've described the procedural analgesia thing in which we're do that, but still for the patients who don't fit that criteria but do have a really deformed arm but don't fit that criteria, we have now moved to a point at which we kind of feel like, actually, well, we should be able to provide procedural sedation for children in more than just the situation that is here on the screen now, because that is the current guidance for us, where limb-threatening fractures, that's when we would do procedural sedation with IV ketamine, depending on who that might be, IV propofol, etc., for the older kids. So the question is, and this is where I'm going to hand over to my colleague Tricia about her quality improvement project in the ED, about how do we move from the situation where, for us to be able to do a procedural sedation using IV ketamine, where you need to have a senior who's airway trained children, etc., how do we get from the situation where that is the stars have to align to that being our bread and butter? And so that's the challenge that we now have, being able to say that in the other group of patients whereby they've got a nasty fracture, it's not suitable for procedural, just procedural analgesia. And I think, to be fair, there's a lot that do. So it's not a lot of patients, this group, but whereby we can get the patients into a comfortable position, and they can potentially come back for an operation. That's something that does happen, but they are manipulated in the ED under procedural sedation. How can we make that more of a reliable service? So with that, I will hand over to Trish for her part.
So I thought where we'd start off is by seeing what difference actually having Matt's team bringing in procedural analgesia into the department as a more sort of a regular thing that we do now, a regular way in which we manage forearm fractures that need manipulation, how that's impacted us. So we had a quick look at data collected between May and June. And now bear with us, we have got a new data. We do have a new software system that is a bit more difficult to get data from at the moment. We're still trying to figure it out. So it's pulled 37 forearm fractures. I'm pretty sure we manipulate more than that on a monthly basis. And given the fact that a lot of those that do present end up being like buccal fractures, where there's actually not that much of it, it's very stable, there's no real periosteal break. The ones that we're really focusing on are mostly our distal radial fractures, and then the kind of more unstable proximal mid-shaft ones. So of those 37 fractures that turned up, 9 were done under procedural analgesia, which is intranasal fentanyl for us and Mentanox. And this kind of all followed our sort of regular guidelines. These children ended up being plastered, they ended up being followed up by a fracture clinic. They didn't need to come back for any sort of operation or anything like that. And that's what we're kind of used to. But what we're looking at is actually there was a certain cohort of children who had quite nasty, either distal ulnar and radial fractures that were completely shortened, impacted, displaced, or were associated with neurovascular compromise. And as classically would happen, it would normally present out of hours when the traditional kind of availability of having a consultant who is sedation and airway trained may not necessarily be present. So 6 of these children that presented in the last month ended up having procedural sedation, mostly with ketamine, one with propofol. And of those, 2 went to theatre for ORIF. So actually looking at the amount of children previously going to theatre for open reduction and internal fixation, or with using things like an image intensifier, we've kind of dropped that to 5%. And I think that is actually fairly representative of where we are in terms of kids now having to go under GA to be able to have their factors appropriately and safely reduced. And next slide, please. So we've talked a little bit about, I think Mr. Shonak and Matt have already kind of touched on GERFT. We've already sort of talked about the ideal patient pathway and the journey. And so what we want is we want procedural sedation to be available to us as smoothly as procedural analgesia is available to us. So in that first triage sort of booking in, we get those x-rays requested, we get those images done so we know what manipulations we need, and then as part of that medical assessment we are seeing whether or not we need to call down our orthopedics colleagues early, because I'm completely in agreement that we should be getting our senior orthopods down here to support us through this. We also have the benefit of being a major trauma centre, which means that we have a registrar available to us out of hours, and most times we don't tend to do their on calls from home as much because we are very busy. Be able to facilitate procedural sedation for them in a way that has to be facilitated by medical staff and not just by nursing staff giving fentanyl and Entonox. And then depending on how their reduction goes and how unstable their fracture is, be able to either get to a neurovascular point of view where they can wait for a CPOD list the next day, or get them to a place where actually they might have completely avoided those K-wires and those flexible sort of nails, and send them home. So next slide, please. So this is an example of one that we did recently with procedural analgesia. It's not to, because we don't like using it, but basically it's off-ended, isn't it? And with a little bit of procedural analgesia, I think if you click again, Matt, it's actually come back fairly nicely, and that's completely avoided sort of the need for any kind of operation or any theatre. And that was then followed up by a virtual fracture clinic a couple of weeks later, and it still was healing in very, very good position. So next slide, please. This is when I think our procedural sedation really kicks in with ketamine. So this is these are images of an 8-year-old boy who, I don't know if you remember back when the weather was sunny and warm, a bunch of people were doing outdoor activities, and this child decided to fall 3 meters out of a tree and landed on both arms outstretched. So on the right, that's his lovely buccal fracture, which was given a simple splint, but on his left, it shows quite an impacted, completely off-ended distal radial ulnar fracture. That was also associated with neurovascular compromise, and as luck would have it, it presented on a Saturday evening at 8 o'clock in A&E. He was in a lot of pain, and I picked up on a couple of words that Mr. Shonak said earlier, which was it can be still painful and quite brutal to have reductions done in A&E. And that's where I think ketamine has a special place, because if someone is neurovascularly compromised, you're probably not going to rush them into theatre to have that reduced at Saturday night. But what you might be able to do is facilitate ketamine sedation. So we gave some ketamine sedation, and this is what the result looked like afterwards. Matt, next slide. And I would say that's a really satisfactory outcome. And again, that child ended up not having to have the surgery required. We've saved them an anaesthetic, we've saved them a general anaesthetic, we've saved sort of possibly compromising their airway. All of this sounds great and is great, but the amount of, and I think it's been hinted on, the amount of training that you need to be able to have a provider that can safely provide that ketamine sedation or even propofol sedation, that's what we're kind of sort of dealing with at the crux at the moment. It's fine to say that we have the service and we can use it, but it's another thing to make sure that we can deliver it safely, because there are still significant risks associated with using sedation over analgesia, even though it may be more appropriate. So next slide, please. So at the moment, our sedation is provided by the paediatric emergency medicine team. It's not done by anaesthetics. It's currently provided between 8 a.m. to 5 p.m. Monday to Friday, depending on the clinician in charge of PEDS and whether or not they are appropriately trained and feel confident. And out of hours, if it's limb threatening, depending on who's available, it's not unknown to call our anaesthetic colleagues down for support. And that's kind of the bit where we want to work on, because a lot of these fractures end up coming as part of traumas, coming as, as part of people playing after school or at the weekend. So if you go to the next slide, Matt, we'll review some of the barriers that's currently what we're trying to work around and identify to make that process a bit smoother, to make it as smooth as our procedural analgesia process. A huge part of this is training and how we deliver it. And really, we're aiming to train our middle grades and above, so our SG3 pluses. And it's open to everyone above that training grade. And it's not just trainees, it's open to non-trainees as well. So again, we're trying to mitigate for that. It's the middle of the night. Who do you know who the SHO or the reg might be? Are they even trained? Well, actually, we're expecting our trainees to be airway competent, and we're expecting now our Caesar doctors to also be to also have done a stint in anaesthetics and ITU. So we're trying to mitigate for that and that airway risk. There is a bit of prevarication depending on how long it takes to set up, because actually we've got a lot faster at giving Entonox and giving intranasal fentanyl. But ketamine still requires 2 of your nurses to go away, draw it up in a cupboard, draw up 3 doses, document all of it. There's making sure that all the moving parts are done in a time efficient way. That's one of our challenges. Consultant supervision is something that we are working on. We have a huge body, and I'm sure Matt agrees with me, we have a huge body of consultants at King's, a lot of whom are very happy to facilitate sedation, or to have their juniors do sedation sort of with their knowledge that it's going on in the department. But that's still something that can be a bit patchy at times. And it is hugely variable with how busy the department is. And I don't think we've been living under a rock for the last couple of years, but it is really, really, really busy. And the person who out of hours, the consultant out of hours who is supervising the whole department, is covering all of resus with the 5 mental health patients needing sedation there and the very sick patients in the corridors. And so that person is also then having to take this overview. So there are lots of moving parts. And so that is a limiting factor that I don't think we'll be necessarily able to solve for this particular project, but hoping to mitigate for that. And then the nursing skill set, they've been very helpful and very keen to work on the analgesia part of you. We just need to get the sort of sedation part in. So the way in which we've done that is we have got a lead nurse for sedation in the paediatric emergency medicine department, and we're working with them at the moment to try and make sure that our nurses are skilled. And a lot of our junior nurses coming through are really keen, and they really want to get involved, and they're seeing a lot of what perhaps the band 6, band 7s are doing, and doing doing supervised sedations with us. So there is shop floor experience that's happening at the moment. If you go back a slide, Matt. Sorry.
Oh, wow. Okay. Yep.
Perfect. What we're really focusing on at the moment, we realise that the rate limiting factor is how well our clinicians are trained, how well our middle grades are trained. And so that's where we're looking at what their competence is like. And there are several ways in which we're going around this at the moment. But the first sort of port of call is to do half-day courses, where prior to that, we're expecting trainees to have a read through the RChem learning module. There is a paediatric sedation module on there, which is really, really good, and it doesn't take too long to do. There is a sim-based course where I'm sure anaesthetic colleagues can fill us in a bit more about this, but we're running through the paediatric airway, we're running through the consent, the risks, the benefits of sedation, and we're running through how to troubleshoot situations which are everyone's nightmare, things like laryngospasm, or just failure of procedure. And those sort of simulations are particularly key, because it's not what happens when it goes right, it's what happens when it goes wrong. And that's what we're trying to sort of manage for in the ED when we provide sedation. We're expecting the candidates who want to be trained to then do a couple of observed procedures with consultant supervision. And we are very lucky that we receive a lot of middle grades and juniors who have, through their previous experience and through their previous training, whether that's through them or through their own sort of peds emergency medicine backgrounds, have already sort of achieved that training and that competence. And so it's sort of trying to get them to sort of feel comfortable and facilitate becoming active and supporting other members of the team as well. So if you skip a couple of slides, Matt, thank you. So in an ideal world, if we were to get it right first time, we would like to be able to do this at all hours of the day. We would like to be able to do it as safely as possible, to prevent as many unnecessary GAs and to prevent as many admissions as possible, to save our orthopedic colleagues from having to do operations that they don't need to, and ideally give a really good satisfactory result of reduction in A&E, and then see how they do with virtual fracture club below clinic. And I think what's really encouraging is that there are, I think less is more often when it comes to sedation analgesia, when it comes to sedation, and also when it comes to how much we manipulate forearm fractures. And there are sort of studies at the moment looking at things like Craft, for example, looking at the way in which we manage sort of things like distal radial fractures. So I'm hoping that in a year's time, we'll be able to provide this kind of service around the clock, and train up a whole sort of batch of middle grades to continue to provide this as well. But yeah, that's me done.